All right, guys, we are now going to discuss the the endocrine system pathology. Okay, so let's start off by discussing the differences between diabetes mellitus, diabetes insipidus. Mellitus means tastes like honey. Miel is, for some of you that speak Spanish, is honey. That's how I remember diabetes, honey diabetes. Okay, that's sweet. Now, there is also diabetes that is called diabetes insipidus. And I go over this a little bit more in detail in anatomy for endocrine anatomy. So you may want to revisit that to kind of review your anatomy. So there is a thing called diabetes insipidus. So diabetes mellitus, diabetes insipidus, and insipidus simply means tasteless, not tasty. And as I said, you know, back in the day when names were given out, there were no, you know, high-end, you know, there was no equipment that could tell you, oh, okay, that little drop of water has, or urine or blood has this much glucose in it, or you know, not, right? So a basic way to examine things was to take your finger, stick in it, and sweet or no. Okay, and I'm not kidding you. Okay, I mean, urine tasting was a thing. Okay, so that's why diabetes tastes like honey versus diabetes that is tasteless. Okay, so obviously in both cases of diabetes, you have a urination, and in both cases of diabetes, you have too much of urination. Okay, and so one patient would have urine that is sweet, one is that means a lot of glucose, and another patient has urine that is tasteless, not sweet. Okay, both patients lose water. So obviously both patients are very thirsty because they lose a lot of water. The term for very thirsty is a lot of thirst, polydipsia. Okay, so both patients with diabetes mellitus and diabetes insipidus obviously would have polydipsia, but remember that if urine is tasteless, i.e. glucose levels in blood and urine are normal, okay, are normal, that means that the patient has diabetes insipidus and diabetes, and not diabetes mellitus. And I kind of mentioned it last time, right? That, okay, I'll go over it a little bit later. Okay, so that's your diabetes mellitus versus diabetes insipidus. Let's briefly touch on what happens in diabetes insipidus, the opposite of diabetes insipidus, actually. It's called, so what causes diabetes insipidus is a decreased production of a hormone that prevents you from peeing. So a hormone that does not let you pee. So let's call it a no pee hormone, and the real name is anti-pee hormone. The real name is anti-diuretic, diuretic for pee, anti-diuretic hormone. Okay, so no pee hormone, anti-diuretic hormone, and you know it as ADH, right? So no pee hormone, anti-diuretic hormone levels are increased. And so what happens is that hormone goes to your kidney and sucks in from the renal tubules all of that urine that has been made by filtering your blood in the glomeruli. Remember, afferent arteriole comes to that glomerulus, efferent arteriole leaves that glomerulus, water, about 20% of it is filtered. That filtration into that Bowman's capsule, And that is the first step of making urine. Now, some of that water will be taken back, most of it, but some of it will be left over, right? And there will be some water, some electrolytes, sodium, potassium, calcium, magnesium, and so on, chloride, right? But remember, we have all of those electrolytes that are surrounded with water. Water never travels alone, right? But we do have this hormone called antidiuretic hormone that essentially forces the body to produce channels called, you might see them somewhere, they're called aquaporin channels that just see that free water that's not surrounding those ions, sodium, potassium, calcium, magnesium, whatever they are, right? And as soon as it sees that water, it just sucks it away from the tubules, back into the body. So you pee out less, right? That's why it's called antidiuretic hormone. And I discuss it in the anatomy that we now know it's the same hormone as vasopressin. Okay, now listen in. So antidiuretic hormone, if you make too little of it, you pee a lot, you have diabetes insipidus. Is it possible that due to whatever reason, we make too much of antidiuretic hormone? And indeed, that may be a case in cases like, that may be a case in accidents like brain injury, certain kind of medications, many medications actually, lung diseases, and quite a few other reasons. Okay, it's a rather common happening in a hospital. Okay, where too much of antidiuretic hormone is secreted, and you tell me in your mind what happens then. So too much of no pee hormone, that means you pee even less, because you say it's like someone yelling, hell no pee, okay? Definitely no pee, okay? So once again, if you don't have this hormone, you pee like crazy because you don't have anti-pee hormone, antidiuretic hormone, ADH. So the patient pees. How much does a patient pee? Do you know that the patient might be peeing about about 3 gallons a day? So obviously that's a huge loss of water. Is that patient thirsty? Common sense. Thirsty as anyone can be, right? So do you need to reabsorb that water? You can't. You lose a lot of water. And obviously the patient is very thirsty. And the opposite of that would be a patient produces too much of that no pee hormone, antidiuretic hormone. The patient doesn't pee at all. Because the patient doesn't pee at all, you don't make urine, but that's only half the problem. What happens is that due to too much antidiuretic hormone, the patients absorb too much water, okay? Too much water that is not balanced by solutes like sodium. And remember, water in the body, you should absorb water. You should also absorb that little bit of salt to kind of balance it, okay? So now you have a situation where basically the sodium levels in the body are very dilute, okay? So very low levels of sodium, low natremia, hyponatremia, okay? And the disease is called SIADH, syndrome of inappropriate, not proper, syndrome of inappropriate ADH secretion. And we call it SIADH, okay? Once again, it can be due to brain injuries or just some other causes, okay? So that would be it for ADH, but let's talk about diabetes. Another cause of urination where patient's urine actually contains a lot of glucose is sweet, right? So that would be type 1, type 2 diabetes. There are some other types of diabetes, gestational in pregnant mothers. Well, let's talk about type 1 diabetes. What you need to know about it is that type 1 diabetes is usually discovered in childhood. And we talked about the pancreas, right? Pancreas has two functions. One is endocrine, where it produces insulin and glucagon and another hormone called somatostatin. But it also has exocrine activity, where it produces enzymes necessary to digest fat, right? So imagine in a patient, usually a kid, all of those all of those areas that produce insulin are destroyed. Just imagine for once. And those areas exist as islets, little islands of hormonal tissue within that pancreas, right? We call them islets of Langerhans, just a name. Okay, imagine you like target, destroy them all. So the patient just doesn't still produces enzymes to digest fats, but no longer produces insulin. Well, that's not very good, because you know what you need insulin for, right? You need insulin to drive in sugars, glucose, into all of the cells in the bodies, every single cell in the body. So what is the likelihood that that kid, and usually a kid, it starts, we used to call it early onset diabetes mellitus, childhood, but we now know it's no longer, not always something that happens in kids only, right? So type 1 diabetes cannot be cured. Why? Because what happens if you don't have insulin? Can you take that glucose and feed yourself? No, the patient will die. Okay. And if you want to help those patients to survive, you need to teach them how to inject insulin. Okay. That's the only way for them to survive. Okay. So insulin production in diabetes mellitus type 1 is not there at all. In type 2, as we went over, it's an insulin resistance, right? So the cells respond to insulin, but very poorly. So they're like, come on, I need more of you insulin to talk to me. Okay, type 1 is such a severe damage, usually autoimmune. We think it's post-viral. There is still, we do have antibodies that destroy those islets of Langerhans, okay, discovered, and absolute need for insulin. Okay, you also need to know a few other, so a few things about the adrenal gland. Okay, once again, this is, I'm just giving you points to remember to add on to what we have in class, right? So you need to know Cushing's syndrome, okay? Harvey Cushing was a neurosurgeon, a very famous one. He described a certain kind of a tumor in the brain, and he described a certain kind of a patient, right? And that would be kind of a big guy who has skin that is kind of torn. But one thing that stood out in that patient was too much of cortisol. And I kind of went over this in the anatomy part. Cortisol is made in the zona fasciculata, the second layer of the adrenals, suprarenal gland cortex. Visit the anatomy videos for details. So layer 1, layer 2, layer 3, and then we have the medulla. And that cortisol has anti-inflammatory activity, but it also, among others, increases, it's a stress kind of a hormone, and it increases sugar levels in blood, okay? So that may also cause increased urination, right? Obviously, that may cause diabetes. That's why someone who has a lot of stress nonstop may present to you as a diabetic patient, okay? So adrenal cortex, the second layer, produces too much cortisol. That's called Cushing's syndrome, okay? And for those of you that might hear, oh, is it syndrome or is it the disease? So just know that Cushing's disease was described by a neurosurgeon. That guy works on the brain, so it starts in the brain, okay? It's actually the too much production of too much ACTH, adrenocorticotropic hormone, that drives the production of cortisol in the adrenal gland. Okay, that's the disease. But here we say Cushing syndrome, too much cortisol. Cushing starts with a C, cortisol starts with the C. Okay, now don't mistake it for too much production of aldosterone in level 1, the most outside part of the adrenal cortex. Zona glomerulosa, fasciculata reticularis. I mentioned that the outside part of the adrenal cortex makes salt, production of salt, absorbing hormone, right? So it produces aldosterone, a kind of a steroid hormone, and that steroid hormone drives absorption of salt in the body. Okay, and obviously for every salt molecule that you absorb, you kick out the potassium. Okay, so Conn's disease is when too much of that is produced, too much of aldosterone is produced. Patients have hypertension. Why is that so? Because hypertension is due to too much salt in this case, too much of sodium. Just like they tell you, please don't have so much salt, you might have hypertension. So Conn's on the outside, Cushing on the inside. Cushing is always on the inside, right? Layer 2. Salt, sugar, sex. Sex hormones are level 3, testosterone and so on. Salt, sugar, sex. Salt, Conn's syndrome. Sugar, Cushing syndrome. Now let's talk about Graves' disease. You know Graves' disease as hyperthyroidism, right? And it indeed is too much of thyroid hormone. Thyroid gland sits here. And you know from your anatomy class that we have a thyroid releasing hormone, thyrotropin releasing hormone. We have thyroid stimulating hormone in the pituitary. Thyroid stimulating hormone talks to the thyroid gland and says, hey, come on, make some of that thyroid T4. Okay. There's also T3s, mainly made in the peripheral tissues, T4. Okay. So that would be your normal production of the thyroid hormone. What if you have antibodies? And we went over antibodies, what they do. What if they just go out, appear out of nowhere and go and sit on the, so I've kind of mentioned the receptors, right? I told you that there are cells and they have receptors that receive that information conveyed to the cells by the hormone. So if I'm a hormone called insulin, I go to the cell and tell the cell, hey, my name is insulin, how are you? And I shake hands with the receptor on the cell. And only that part of the cell, that receptor recognizes me, recognizes what my message is. And my name is insulin. What would I be doing? I would be telling, hey, cell, why don't you take all of those glucose molecules and let them go into the cell? And that's what the cell does. So if I'm a thyroid hormone, I go to and I sit on another cell, the thyroid, one of the cells of the thyroid, and I talk to that cell and I say, hi, how are you, thyroid? Remember who talks to the thyroid cell? Thyroid stimulating hormone, right? So we have the thyrotropin releasing hormone in the hypothalamus, which talks to the thyroid stimulating hormone. Thyroid stimulating hormone goes and talks to the thyroid gland, okay? And the thyroid gland recognizes that TSH, thyroid stimulating hormone, that stimulates the thyroid gland and says, cool, I recognize you. Your message is for me, the thyroid gland, to make a lot of T4, thyroid hormone. Cool. That's what normally happens. Now, there is an antibody that pretends it's a thyroid stimulating hormone. So that antibody goes, finds that thyroid stimulating hormone receptor on the thyroid cell and tells it, hi, how are you? I'm thyroid stimulating hormone. It just goes there sits on it and doesn't ever let go. So what does the cell think? Yeah, thyroid stimulating hormone is talking to me. I should produce thyroid hormone, the T4. And normally what happens is that T4 is produced, goes back, and negative inhibition happens, right? That thyroid, the T4 hormone goes back, talks to the thyroid stimulating hormone, talks to the thyrotropin releasing hormone in the hypothalamus, pituitary, and says, there's so much of me, please slow down. That never happens. Why? They are already down because so much of T4 thyroid hormone is swimming around. So the elevation of T4 is not due to these two hormones. They are down by negative inhibition. Elevation is due to the antibody. Okay, so hyperthyroidism is not normal. It's a disease. Okay, antibodies go and sit on top of their cells and cause production of the thyroid hormone T4. Okay, what else does that antibody do? What other problems does it cause? Well, it goes behind the eye and causes problems there, an inflammation. So there is an inflammation around that fatty tissue behind the eye, the orbit, and that inflammation causes the eye to actually move forward. And you know, we see that as bulging of the eyeballs, but the reality is it's not a stare. It's actually the eyeball that is actually pushed forward. Okay, that's very important to know, because if you were to look from the side, you can actually notice the thing called proptosis. Another word, exophthalmos. Ophthalmos, the ophthalmic ball, the ball of the eye, X on pushed to the outside. Okay, and Graves' disease is presence of those antibodies that causes hyperthyroidism due to too much production of T4, right? And as a side, on the side, you may also notice exophthalmos. Okay, they usually go hand in hand. Okay, remember, exophthalmos is not found in normal hyperthyroidism. So if a patient has a tumor that produces too much thyroid stimulating hormone in the pituitary, patient will not have exophthalmos. Graves' disease is a problem with the antibody that causes a damage in the eye, behind the eye, damage to the thyroid gland, okay, which produces too much thyroid hormone. The opposite of hyperthyroidism is hypothyroidism, and that would mean decreased thyroid hormone T4. And you know that, you know, hyperthyroidism usually goes along with people losing weight, being hyperactive, and you know that stare that is so commonly described. It's not because they're like so hyper, it's because of the damage, right? So hyperthyroidism, but the T4 hormone actually does make you very hyperactive because it so-called increases metabolism. The endogenous, the body's own metabolism is increased. Patients are more, much more active, hyperactive, much more active than their normal level. Opposite of that would be decrease in the thyroid T4 levels. So patients are hypoactive. How are you doing today? I'm doing very well. Nice. So that would be your hypoactivity. Okay. They gain weight. Why? Because they are not as active anymore. So if you eat the same amount of food, their metabolism is decreased. They don't utilize all of that food for nutrition, right? So they gain weight. All right. So remember, weight is increased and the basal metabolic rate is decreased. Okay, and hypothyroidism, decreased thyroid hormone. Now let's talk briefly about sex hormones. So in females, right? That by definition, delayed puberty means delayed appearance of secondary sexual characteristics. And if that does not if secondary sexual characteristics do not appear on a lady after she's 12 years old or more, we call it delayed puberty. Okay, what does that mean? Appearance of breasts, body hair, and distribution of fat in general, where you say the girl is now a woman. Okay, so there are a few diseases that you need to know. I kind of go over endometrium. So we have a myometrium, that's the muscle of the uterus. We have the inside of that myometrium, that's called endometrium, right? So what happens is that that endometrium may be inflamed. Any inflammation of anything is called itis of that thing. Inflammation of the endometrium is obviously called endometritis, right? So can it be due to infections? Absolutely. Sexually transmitted diseases, most common bacterium, for example, would be chlamydia, right? You need to know that. Chlamydia, how to treat doxycycline? One time. And if you want, if someone is allergic to doxycycline, azithromycin, and if someone is allergic to azithromycin, you give doxycycline. Okay, so that would be okay. So chlamydia, sexually transmitted diseases. Okay, that would be it. Let me see what else I need to discuss with you. Okay. So endometritis due to infections, STIs, but also do not forget there is a chronic condition of the endometrium possible. That's called endometriosis, the chronic condition. Osis usually means chronic condition versus itis, right? And that is a rather common condition where it has been noticed that a certain group of patients have, obviously females, menstruating females, have extreme pain during menstruation, especially during menstruation. And so what was noted was that it's only during menstruation that they have more unusual pain, so bad that, they might miss work, okay? And, or, they cannot get pregnant. Infertility may cause infertility indeed. Endometriosis is that endometrium, due to whatever reason, we're not sure yet why it is. So there are a couple of theories. What happens is that parts of that endometrium are found not in the inside of the uterus, but are found somewhere else in the body. For example, if they're found in the ovaries, then obviously infertility is the cause. Why is that? Why the problem? Well, what happens every month with this endometrium? Every month, a female menstruates, right? So that tissue sloughs off. What is special about this tissue is that it responds to hormones, right? It responds to hormones produced in the body as a response, which are cyclical in nature, which happens every month. So every month you have this endometrium building up. And if the lady does not get pregnant, all of that tissue just sloughs off. You lose it, right? So what if I have that uterine tissue, the inside, the endometrium? Let's just put it here, on the top of this mouse. Crazy, I know, but it'll help you remember. Okay, so, and I apply the same hormones that the lady, and I keep it there for a month and I keep it alive and connect it to a female. Okay, well, you're gonna see growth. As the month progresses toward the middle of the month, you're gonna see growth. And then obviously divide, grow, cells divide. And then if the lady does not if she gets pregnant, it will remain at the same maximum level that it grew to, right? But if the lady does not get pregnant, what happens? That part is supposed to slough off and die. Because why does that happen? Because it does not receive the hormonal stimulation anymore, right? So that tissue is essentially has been marked to die, to leave the body by the body hormones. Now, in the uterus, that that tissue just leaves the body, right? We call it menstrual bleeding. What if that tissue is found somewhere, let's say in the ovaries? That doesn't happen. So it just dies there, right? And waits for another monthly cycle to build up. So these cycles of bleeding and dying and building up, menstrual cycles, happen in the ovary. Not too good because it obviously hurts. So whether it's the ovary or any other part of the pelvic cavity, it's very painful. So depending on how much of that tissue is outside of the uterus, endometriosis can, or where it's located, endometriosis can be an inflammation that is very, very painful. Endometritis, right? Endometritis. Let me speak. So endometriosis can be a very dangerous thing. Endometritis, on the other hand, is just a bacterial inflammation of this endometrial tissue in place. So when we say endometriosis, it's a chronic condition outside of the uterus. Osis, think for you, outside of the uterine cavity, okay? I just looked at my notes here, what I need to talk about, and I just read endometritis and without thinking. So, all right, so endometriosis, basically endometrial tissue that is outside of the uterus. You need to know some terms. There is a term called heavy menstrual bleeding. Heavy menstrual bleeding. This is the same term that you may see in older books as menorrhagia. Rhagia means flow, meno means monthly flow. And we used to say, okay, the flow that is more than 7 days in length. Okay, flow that is, so and so many pads. But now we've come away from that. And the generic term is just abnormal uterine bleeding, okay? And some people might still say menorrhagia, heavy menstrual bleeding, okay? Heavy menstrual bleeding, menorrhagia, more than 7 days. You might still see it in older books. And so I know it's in your learning guide, so I wanted to kind of bring attention to it. Last thing that I want to talk about in endocrinology would be polycystic ovarian syndrome. Not too much I can talk about here. We still don't know why it really happens. We only know that it's the number one most common cause of ladies coming to the fertility clinics and saying, hey, they can't get pregnant. And when you look at it, it's the number one cause of anovulatory infertility. That means there is an ovary, there are eggs, but there is no ovulation. The follicles do grow in size. You look at the ovary, wow, there are so many of those follicles. None of them actually, jumps the ship, ejects from the ovary and goes into the fallopian tube. We kind of know the pathophysiology, but we still don't know why it's there. We have a few theories. Polycystic ovarian syndrome, most common endocrine disorder in women of reproductive age. Okay, and once again, the number one cause of for anovulatory infertility, and anovulatory infertility simply means there is no ovulation. And ovulatory, no ovulation, just like anemia, no hemia, no blood. Okay, that completes endocrinology. So off to the next group of questions.